Hello, Dr. Tine. I appreciate your time today speaking with me at the CTOS 2017 conference. Dr. Tine is the chief of the Sarcoma Center at the Siteman Cancer Center and Barnes & Jewish Hospital. Thank you, Dr. Tine. Today, what do you feel are the best treatment options for LMS, depending on the site location? What are you using?
You know, I think that a lot of things haven't changed very much. I think the standard frontline treatments for LMS at this time are still chemotherapy-based. You know, with the new addition of something like alertumab, I think we have a better tolerated frontline therapy. You know, this has shown an overall survival benefit. We published a uterine subset recently showing that whether you had standard LMS or the uterine kind of LMS, these drugs seem to show the same thing. You know, then you have things like gem and docetaxel, trabectedin, you know, dacarbazine if you have uterine leiomyosarcoma. You know, and then there's some of the things that are coming out in clinical trial. You know, there have been a number of responses personally in my clinic to a combination of immunotherapy with ipilimumab and nivolumab, but I think this is still best done on protocol.
Thank you. And in terms of metabolic alterations in LMS, is this an important focus to potentially increase treatment protocols?
Yeah, so one of the things I've worked on is defining a urea cycle defect that's very common in about 90% of leiomyosarcoma. Most leiomyosarcomas don't express an enzyme called arginosexatase synthetase 1. And what this does is help leiomyosarcoma cells make their own arginine, so they can't make it at all. And so there's a drug available called arginine deaminase that destroys all the extracellular arginine, and this can be used to begin to starve leiomyosarcoma specifically within a body. One of the things that my work has shown is that this makes gemcitabine work better. So there's a trial that's opening up very soon where we're going to do gemcitabine, docetaxel, and arginine deaminase, and we really want to focus on leiomyosarcoma patients to see if we can get better responses.
That's wonderful. That's great. When will that come out?
I'm hoping that we will open in the next 4 to 6 months.
That's wonderful. Great. Thank you. And how about aldoxorubicin? How do you feel that'll work out for patients since it's less toxic? And do you think it has potential to be combined with olaratumab?
I'm not actually sure what the fate of aldoxorubicin is going to be. I know it was just licensed to NANT, but I haven't actually seen if it's going to be FDA approved, and so it's really hard to know what to tell people about this drug. It's kind of gone dark in terms of what I know about, in terms of what's happening with it.
Okay. My last question is genomic sequencing. Does it help to clarify a definitive diagnosis or treatment plan? Is it part of an integrated in your care system?
So we sequence a lot of sarcomas. I found that sequencing leiomyosarcoma has been very relatively low yield for identifying things of surprises. I think the TCGA Cancer Genome Atlas project that was just published on leiomyosarcoma sort of shows that there's usually not a surprise within leiomyosarcoma that you can go after. But, I mean, it's always worth doing, but it's something that I wouldn't hang your head on changing your treatment pattern.
Do you suggest that patients themselves that would want to seek genomic testing not go that route? Or?
No, I always think it's worth doing on the off chance you find something, but I don't think it's a make or break, live or die test that you have to have right now if you have leiomyosarcoma. I think if you had something like undifferentiated pleomorphic sarcoma, there's very specific good reasons to sequence that one. I haven't found a really good reason that we'd be diving in looking for something to drug.
Okay, very good. Well, thank you so much, Dr. Tine. I appreciate your time today. Thank you very much.
Oh, and it's always good to talk to you.
Thank you.